Good afternoon, everybody. I'm Melanie Escher with the Arizona Telemedicine Program and the Southwest Telehealth Resource Center, and I'm here with Ernestine Nasingwaitua with the American Indian Health AHEC. And welcome to our presentation today. I'm going to go ahead and do just a few welcome slides. Let me get the right arrow. We respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The Southwest Telehealth Resource Center represents Colorado, Arizona, New Mexico, Nevada, and the Four Corners region, with a combined total of 72 recognized tribes. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. So as you joined us today, your phone or your computer microphone were muted. We will be able to utilize the chat function for any questions and answers. Please, by all means, please use that chat feature if you have any questions. We also have a post-webinar evaluation that will pop up in its own URL window in the background. Please go ahead and fill that in for us. This is where we get ideas for future talks and presentations, things that you would like to hear about. This is being recorded and it will be posted on our website. You can see the URL there. I'll post that in the chat, and I'll also have it in a thank you email to everybody. So don't worry about copying all this information down now. You will get it as well when we're done. These are the continuing medical education, the outcome objectives, the accreditation statement, and the disclosure statement. There's a code that can be found in the evaluation. If you haven't set up your profile, there's instructions on how to do that. It's through the Cloud CME, through the the University of Arizona's Department of Continuing Education, Medical Education. That information will be in the thank you email as well. And go to the next one. We have our standard disclaimer. Give you a moment to read that. And please be sure to check our website for future upcoming webinars and events. That will also be in the thank you email. And again, here is the survey link. It will pop up in a URL, a web page, website page when we're done. But I will also have that in the thank you email, and I'll put it in the chat. Today we have Siren Lipschutz. She's a clinical manager with Teros Inc. She's going to be doing our talk today on maternal mental health and wellness. I'm going to go ahead and stop sharing and introduce to you my co-partner in this process is Ernestine Nasingwaitua, and she is with the American Indian Health AHEC. And Ernestine?
Yeah, thank you, Melanie. Hi, everyone. Welcome to today's webinar. This webinar is a partnership between the American Indian Health AHEC and the Arizona Telemedicine Program and Southwest Telehealth Resource Center. And today we're also partnering. A big shout out and thank you to Postpartum Support International. Today's presentation by CRAN is vital. Maternal mental health is crucial in Arizona as it directly impacts families, long-term health outcomes, and communities. Just a short background on American Indian Health AHEC. So the American Indian Health AHEC is one of six area health education centers in Arizona. The American Indian Health AHEC works towards enhancing tribal healthcare systems and strengthening current workforce strategies and solutions. The American Indian Health AHEC is involved in a variety of activities, including youth healthcare career exploration programs, community-based experiential training, AHEC Scholars Community Immersions, and also events like today, continuing education for healthcare professionals. I want to thank you all for joining us today, and I'll give it back to Melanie.
Great, thank you very much. All right, Siren, if you would like to go ahead and pull up your slides, we'll get you started. So she works as a therapist with the Havasupai tribe in Supai, Arizona, is a doctoral candidate at Northern Arizona University, provides trainings on topics including work-life balance and maternal perinatal mental health. CREN clinical specialties are maternal mental health, direct trauma, and generational trauma. Her doctoral work focuses on how urban Native families in Flagstaff, Arizona experience, define, and heal from stress and trauma. And most important, CREN is mother of two little boys and lives on the edge of the forest outside of Flagstaff, and she takes wellness very seriously, loves to read, paint, bake bread, and get outside. So without any further ado, I'm going to go ahead and pass the mic over to CREN, and here we go.
Hi, thanks. Um, so I just want to make one correction. On a previous slide, everything you just said, Melanie, is correct. I am not the manager of Teros anymore. I left that position a year and a half ago. I think that probably was info that is still on postpartum supports website. So but yes, everything else is correct. And it's always funny to hear somebody reading my own information about me. So okay, I'm going to get going. I will not repeat what's on this slide because you just said that for me. So, however, I am going to add a little more of an introduction of who I am, and I will also tell you why. So I, first and foremost, am a mom to two little boys, a 9-year-old and an 11-year-old. I did have a postpartum hemorrhage with my second, and despite my clinical specialty and everything I know, I wonder if I would have had two if that had happened with my first and not my second. So I never had perinatal mental health issues at all, and I will actually talk about that a little bit later in the presentation. But I did have trauma, which does count as well. So my work as a therapist largely has been in Nav Nation, on Hopi, and down in Supai. And I am back working in Supai, where I used to work 6 years ago. I hike down there, I stay for a week, and then I helicopter out. And so much of who I am and how I do therapy comes from the work in the canyon and also on the other reservations. That has also led me to the dissertation that I am currently in year 5 of. So there may be an end in sight. My introduction to generational trauma, however, was in my own home. My father was a Holocaust survivor, or rather, he fled the Holocaust as a toddler. And I didn't know until really a few years ago when I finally had the language for it, I didn't know that that is what was happening in my own home, was probably his own generational and religious trauma. He left Judaism as a teenager. And so there was a lot of trauma from multiple angles. The generational trauma that I'm familiar with personally is very, very different from the generational trauma that Native American families experience and that other cultures experience. At the same time, it's a slight window into it. I am also an alcoholic with 22 years sober, and that has informed my practice a lot as well. I have had my own mental health struggles with both trauma, anxiety, and I have ADHD. All of these things inform how I practice. And when I began as a clinician, it was considered really inappropriate to say any of this in a forum like this. Too personal, too much information, it discredits me even, some people would say. But I think it's really important that we do share our stories. And being able to share my story has helped me build trust with other people who don't want to share their stories with me if I'm not sharing anything with them. It's a give and take. And that's huge in the communities that I work in. It also has taught me so much and informs my practice in other ways. As someone who is neurodivergent, I am able to understand how that feels and that clinical tools often don't work for people with who are neurodivergent, because they're for people who are typical. And so it's made me feel stronger, and it's made me feel like a stronger clinician as well. I go out of my way to share this because so many of us are really uncomfortable bringing ourselves into our professional worlds. And we actually cannot detach parts of ourselves. Our brains are in our bodies, and when we walk into a room, we take it all with us. Knowing boundaries and how much to share and not is important. But also being human is incredibly important in clinical settings. It feels very obvious to say that, but so many of us are discouraged. Thank you, by the way, for hearing that. So our objectives for today are to recognize the signs of maternal mental health struggles, understand stigma and fear and how this affects the communities that many of us are working in, identify skills and resources. So I'm going to provide just a few tools and also talk about what we already have. Sitting here today, what we all already have that we can bring to this work. And that feeds into how you and your education can impact your communities. And before anything else, I would ask, if the chat is open, if people want to put their name, actually, I don't even need names, but what your role is, what your maybe where you work and what your area of expertise is. That would be helpful for that last piece. Okay. So signs and symptoms, good place to start. So during this section, we're going to look at what is perinatal mental health. And I am switching the vocabulary from maternal to perinatal at this point. I use maternal because it eases people in. It's a familiar word, but perinatal is really what we're talking about. What are the signs and symptoms? What are some common myths? And I'll share some examples that I think are really illuminating and add a lot of great perspective. So some definitions. Again, switching from maternal to perinatal, and I still largely talk about mothers when I talk about perinatal mental health. But it's really important that we also realize that partners and families and gender non-binary and otherwise identifying individuals, birthing people are part of this and cannot be left invisible. We need to be recognizing what people look like who are having babies and what their community and what their systems look like around them. The perinatal period is the period of pregnancy, during birth, and then postpartum. Postpartum is the period after birth. And I like to leave that really, really wide open. And more often, I'm seeing this, that we are leaving it wider open. So it doesn't just include after birth. It includes after miscarriage, it includes stillbirth, but it also doesn't just mean the first 3 months or the first 6 months or the first year. It can be years, especially if we're nursing, those hormones might still be coursing through our bodies, keeping us in that postpartum period, which can be good. It can be not so good. It can be neutral. PMADS is still an acronym I use, perinatal mood and anxiety disorders. They include a list of diagnoses, but it also needs to be understood that they involve all of these other factors too. So we know biopsychosocio or a biopsychosocial, for example. I add cultural because I think it's a real disservice if we don't. And I think this topic today really shows that. So the biological, psychological, social, and also cultural factors that come into play during the perinatal period. And before I ever had kids, I heard this, that the perinatal period is arguably the most complicated life stage. And I don't really think it's arguable. I think it's definitely the most complicated life stage because of exactly that last point, the biopsychosociocultural. Oops. Sorry, lost myself for a second. Okay. So again, what is perinatal mental health? This is not a direct answer to that question, but this is part of what it includes. So it's universal. The reason I say that is because I am a white lady with a lot of privilege. And even though I have my own list of issues, I'm still very privileged. And I gave birth in a hospital where everything was paid for. That is unheard of. Yet, women in general, women across the world, have trouble when they're pregnant, birthing, and postpartum. Families, people do, because we are not trusted with our own bodies, because we don't even realize that we need to educate ourselves, because we might not have the person that we chose as our doctor be the person who shows up. We might not have social support, etc. So it's a really challenging period for anybody. And then it gets exponentially harder if you are from a non quote unquote dominant, from a non-white, a higher risk community, the further you are from services, etc. And so it's something that we can all understand if we've been pregnant, but gets more challenging depending on our social factors. So I like to just remind people that the baby blues is often brought up as synonymous with postpartum depression. It is not. Most people experience something like the baby blues that goes away quickly. Language is really important. And so it's important not to not to synonymize words that are not synonymous. It includes anxiety, depression, rage, OCD, bipolar, trauma, and very rarely psychosis. All of these are diagnoses that exist outside of the perinatal period, but they're different during the perinatal period. There is a statistic that 50% of women diagnosed with bipolar are diagnosed during the perinatal period. So whether that's because more women are seeing doctors and the doctors are catching it, which is probably part of it, or these hormones are ramping this stuff up, or they are speeding up the presentation of diagnoses. A note about psychosis, which I don't talk about a lot, other than to say, again, it is extremely rare. Also with linguistics, we really need to be careful not to confuse postpartum psychosis with other postpartum issues or perinatal issues. If somebody is experiencing psychosis, it is an imminent emergency, and that person needs to be taken to care immediately. Starting at an emergency room is a great way to start. It is highly, highly, highly treatable and generally goes away if it's treated. And that is true with all of these, in fact, because they are so related to the perinatal period, related to hormones, etc. They are so treatable. Okay. What are the signs? So how do we recognize this, right? So not what does somebody say to us, but what do we see when somebody walks in the door? Because they might not have the words to say it. They might be afraid to say it. They might not know they need to say it. So symptoms tend to mirror those during other life stages. So if somebody has postpartum depression, there's a good chance they're presenting with depressive symptoms. If somebody has postpartum or perinatal OCD, it's going to look like OCD. One of the nuances is that often has focus and features related to the baby. So OCD is a great example. When there are dirty diapers involved, OCD might be related more to cleaning than it would otherwise. Men and partners are more likely to develop postpartum OCD because of the fear around dropping the baby or something bad happening. That doesn't mean that OCD just appears out of nowhere for these people. It means that they have the combined factors that make it present during that particular period. These are also exacerbated by other parts of the perinatal period, like sleeping and eating. So we all know that not getting enough sleep can ramp up our anxiety. Not eating enough can increase depression. And so we need not to just be looking at what is depression and what is anxiety, but what is the holistic picture? And might it be a lot worse because somebody's not sleeping enough? Which is a quicker fix if you don't have a baby involved. So fairly hard to increase sleep when you have a newborn. And so it's about looking at how do I manage this in this particular period. Isolation is a big one. A lot of people don't want to say that they're struggling because, you know, we're supposed to just be amazed that we had a baby. We are supposed to not complain. It is about the baby. It's not about us. That is so not true. And so people can hide away. If they just tuck themselves away, nobody's going to notice anything is wrong. And unfortunately, that is often true. And that's when sad things happen. Testing the waters was kind of the opposite of isolation. You know, like maybe a woman says something like, hey, you know, have you ever heard of a woman who didn't connect with her baby? Instead of saying, I'm having trouble connecting with my baby, sometimes we test the waters. Testing the waters can be thought of as attention seeking, right? And that's another thing that we stigmatize so much is attention seeking. Like, oh, they just want attention. They're just seeking attention. I truly believe that if somebody is seeking attention, they probably need attention. And so we need to give them attention. If somebody doesn't have the words and the confidence to ask for the attention, we shouldn't hold that against them, and we should still give them the attention. Trouble breastfeeding and other things that make you feel like you're broken, like your body is not doing what it should. Maybe you do feel really broken. Maybe you have stitches. Maybe you are incontinent. Those things can really, really throw off your sense of identity and autonomy. Missing appointments. This is similar to the attention seeking thing, which is it's really easy to miss appointments when you have a newborn. It's really easy to miss appointments when you don't even want to get out of bed because you are 8.5 months pregnant. And sitting in a car sounds like the worst thing possible. That's okay. We can still call and check up and encourage them to come in. Instead of saying, oh, it makes sense that they missed their appointment, they're overwhelmed. Let's make sure that they are okay. Negative self-talk. Does it go further than just like, oh, I just feel like I'm failing? Do they feel like they're failing to the point that they are actually considering giving up? And then comparison. Comparison is the enemy of joy. And we do it so much as humans, but in the perinatal period, it is like our MO is comparison. Like, she's so much happier than I am. How did she get her body back? Why can't I do that? Why isn't breastfeeding working for me? Why are all the other mothers happy and I'm not? Chances are they're not either. They're comparing themselves to everybody else too and trying really hard to cover it up. I mean, this doesn't mean that we're all miserable when we're postpartum or pregnant. It is a wonderful period. And when we don't feel wonderful, we tend to try to hide that. Oops. Okay, good. My fingers are like, I talk too much with my hands, so I'm just randomly skipping slides here. So specifically for Native families, everything I just named is, of course, applicable potentially to Native families as well. And a lot of these are applicable to others. When I say increased risk of isolation here, it is often easier to isolate when you're already in an isolated place. And for a lot of Native communities, they are already quite isolated. Increased risk of missed appointments. Again, there are all of these factors that increase the likelihood that Native folks can't get to their appointments. Transportation issues, the bus isn't running, weather, etc. And there are a lot of racist tropes that go along with it. And so we need to completely shed any of that and assume that we need to check in and make sure they're okay. That itself can be hard. Communication is also often hard when infrastructure is weak in terms of internet and phone. Missing cultural events. So this is both potentially a sign and also a risk factor. So I had a client who lost a family member while she was pregnant, and she couldn't go say goodbye. She couldn't be at the funeral, etc. Because being around death while she was pregnant was considered really risky. And it was considered a danger to her and the baby. So this made her depression worse, and also stood out as a sign to look for, right? This might be increasing her symptoms. We need to make sure she's okay. Incongruity across generations. So if you and your parents and grandparents don't agree on how birth and postpartum should look, it can increase stress and potentially increase your symptoms. increased risk of drug and alcohol use or exposure to it. So, of course, this is an increased risk for any perinatal woman, any perinatal family member. And it is more increased in certain communities, including a lot of Native communities. In communities where a lot of neighbors are engaging in alcohol use, for example, coming home with a baby when family members and neighbors may be engaging in alcohol and drug use, it's hard to stay away. This is something that I've seen in Supai a lot of it's so hard to stay sober when everyone around you is using. And so if even one person in your house is, but we also have to really, really be careful how we talk about drug and alcohol use. We have to get rid of this idea that there's choice involved. Addiction is not something that any of us asked for. After I had been drinking for probably just a few months, it was no longer a choice I made. It had its talons in me and was fully out of my control. And so we need to support these families and never stigmatize and never shame. It doesn't matter if you just had a baby. It doesn't matter if your system's involved. It is really hard to get and stay sober. And shame has there's not a whole lot of research that shows that shame is the way to help somebody get and stay sober. Increased risk of exposure to violence, again, similar to alcohol use and exposure to it. And then gossip. Again, this is a hard one for anybody, but in small communities where everybody knows everybody, so whether you are rural white or living on Hopi, right? Everybody knows everybody and everybody's talking. It is a natural human thing to do. And we don't even consider how harmful it can be. And so if we're hearing gossip, if we're aware of gossip in the community, check on that person that's being gossiped about. I recently learned that I was able to go to a funeral for a young person, and the parent wasn't. And I wish I'd known that. But more than that, I wish I'd known the gossip that was surrounding all of that, because not any part of it was accurate. And I could have gone above and beyond to reach out to the parent. So again, these are not comprehensive lists, right? We have to learn our patients, even if they're there for 20 minutes. Building rapport, making eye contact, right? That's incredibly important. So common myths. Again, postpartum, sometimes it's a year after birth, sometimes it's 3. So often women are not screened. We need to screen, screen, screen. Unfortunately, I will also talk about how screeners fail us consistently. So women are sometimes screened, but they're usually asked very general questions about depression and anxiety. And I recently, just to test this out, I recently asked some folks with ADHD to answer a depression screener. And they were not depressed, but they screened in because their symptoms of ADHD mimicked the symptoms of depression. And so screeners serve a purpose, can be great. They can pick up on things that we didn't see. They can be time savers, but they so often are overgeneralized and overgeneralized to white people. And depression and anxiety are only a couple of the issues. That's not trauma. That's not bipolar. It's not OCD. The idea that scary thoughts are dangerous. So scary thoughts are, I'm going to drop the baby. Even things as scary as I keep picturing myself throwing the baby. Statistics show that between 70 and 100% of new birthing people have scary thoughts, and they can be really, really scary. But the protective factor is that you're horrified by them. And if you're horrified by them, they are probably not dangerous. Yet what happens is, oh my God, this woman just shared that she has actually pictured herself throwing her baby. So now I'm going to call DCS and get the system involved and see if they'll take her baby, because she's obviously not a good mother. I wish that didn't happen, but it does. Depression, again, common myths, that depression is the most common postpartum diagnosis. We've all heard of postpartum depression, and we all need to stop talking about only postpartum depression. We need to reframe this so that we are talking about postpartum anxiety, OCD, perinatal bipolar, perinatal depression, etc. Because it can happen while we're pregnant, while we're postpartum, and it can happen during birth. Birth can cause trauma, etc. That postpartum depression may lead a woman to kill her child. It's psychosis. It's postpartum psychosis where we're at risk for this. And saying that postpartum depression can lead to that makes fewer and fewer and fewer women want to admit that they have symptoms. Postpartum diagnoses are in the DSM-5, the Diagnostic and Statistical Manual. They're really not. There is a single diagnosis. Otherwise, you have to diagnose a general diagnosis with a perinatal onset. And great, we can still do that. But really, these need to be recognized because they are so prevalent. Psychosis is common. Again, it's not. Only women are affected. Again, they're not. Partners, other birthing people, etc. Family members, right, as well. Other kids in the house. And that all therapists have the same training. I feel like a snob when I talk about this, and then I have to check myself and realize, no, I feel this way out of protection for clients. Understanding of the complexities of the perinatal period is critical if you are going to try to treat it. And so most therapists have minimal training in this. And some therapists can do harm. And so I know that just adds, it adds another layer of stress, but we have to vet people and interview them and make sure that they know what they're talking about. And that's really, really, really hard when there's a single therapist in a community. Okay, I'm going to whiz through these so that I don't get jammed up on time. So I like these examples. I will tell you, I have permission to use all of these. Names have all been changed. All of these names are goddesses, which I started doing years ago when I first started doing trainings, because just to honor these women, right? And because I was named after a goddess, and I use myself as an example. So just wanted to put us all in this goddess pantheon. So Anat had psychosis in her first trimester. This woman was a friend of mine. This was terrifying. She was imagining herself violently harming her baby and herself. And I won't go into further detail, but it was really horrifying. Um, and as her friend and not a therapist, it was also this challenge for me for how to help her. She got help, but her second, third trimester and postpartum periods, she was fine. She was totally fine. It was gone. She hardly even had time to find somebody to help her after going into a crisis unit for 24 hours. And then she was fine. And still is. I still know her 10 years later. So Freya had OCD in 3 pregnancies, but 3 different trimesters. So she had OCD in postpartum with her first, during her first trimester with her second, and during her third trimester with her third, which was this huge relief to her because during the third trimester, she was so panicked that it was just going to last forever. She had the baby. And when she stopped nursing, or actually she had the baby and her OCD symptoms went way, way down. She does still have some OCD symptoms, but extremely light. Yamaya had depression with her first, nursed for 3 years, and then had her second, nursed for another 3 years. Would not get help. It wasn't until her husband threatened to leave that she started seeing somebody and started feeling better very quickly. But we know that she would have felt better so much sooner if she had gone to see a therapist and ultimately started on a medication. I'm gonna skip the next one. Diana had anxiety, and it was throughout her pregnancy and then went away. Atira, she had a perfectly great pregnancy. It was unplanned, which stressed her out, but it was pretty good. She felt really empowered. And then 3 weeks after the birth, she had a critical hemorrhage. She was told over the phone to take 4 Advil, so that she would start clotting and stop bleeding. And so repeatedly was told by an OB not to go to the hospital. And by the time she went to the hospital, she was unconscious and needed a blood transfusion. She is a current client of mine and wants to have a second baby. And so the work we're doing is around getting her to a stable place and then a strong enough place that she can consider getting pregnant again. And there's me. So I have OCD and anxiety that presented before I was ever pregnant. And when I got pregnant, it went away. 100% went away. So I was pregnant, I nursed, I got pregnant again. I had a hemorrhage. It was traumatic. I had a neurological event and I had to have a blood transfusion, but I also was never diagnosable with PTSD. And I think that's largely because of how protective my perinatal hormones were. And so it wasn't until my second started weaning that that my symptoms started coming back. So I'm a different case. I had the opposite. I lost all my symptoms and it was wonderful. And then Anja, I wish I had more time. She is a Native woman who had depression and tried to kill herself with pills that she was prescribed for a C-section. During that time, her baby was removed and immediately placed in a family, in a white family. And so what that means is the state did not do what it was supposed to. It did not reach out to the Indian Child Welfare Act and go through that process. And so that increased her depression. It increased her suicidality. She also is from a community where taking medication um, is considered against beliefs. And so she felt all of this guilt for doing something that was against her beliefs and using a method that was against her beliefs. Fortunately, we were able to contact an ICWA attorney, and she's one of the best moms I've ever known. And she has her child. She has had a second child and is doing great. But this is what happens when we don't treat people the way we're supposed to. I'll talk briefly about stigma and fear. When we are seeking help for our physical, for our mental, we go to these places. We go to IHS, community health, primary care, OB-GYN, midwives, if absolutely necessary, emergency departments, urgent care, maybe a mobile clinic. For our mental health, if we're lucky, perinatal mental health therapist. Be great if they were fully certified, and also training goes a long way. Another therapist, psychiatrist, which largely prescribes medications, calling a crisis team, going to groups, substance use treatment, social services, and peers, right? Social services often come in when DCS has been called. Social, we turn to our friends and family, media, magazines, advice and commentary, observation of others, self-help books, and groups. So, in other words, for those social factors, we're looking at others. And if we're comparing to others, that ramps up our risk factors. In fact, perfectionism is one of, if not the top risk factor for perinatal mental health issues, needing to be perfect, which nobody is. So that is automatically an unrealistic hope. And then cultural. We go to our families, to community traditions, to rituals and ceremonies, perhaps traditional healers or religious advisors. In general, resources are extremely limited, but for Native families, it gets smaller and smaller and smaller. And so when we look at these lists, if there's an IHS clinic, people can go there. If there's other primary care, people can go there. Is there even an OB in the community? Is there an urgent care? Is there a mobile clinic that's been brought in because there aren't any of these things? So I put this here to consider how hard it is to get help. Looking at risk and resilience. The risk factors are over here. I put resilience in here because whenever we talk about issues in Native communities, we have this awful tendency to act like there's this hopelessness when it's exactly the opposite. There's so much hope. There's so much striving to get more services, to have services recognized, right? To have traditional services recognized, to have paraprofessionals recognized, to have peers recognized, right? And all of that is a move in the right direction. These risk factors are for Native women, 2 times more likely to die of pregnancy complications, higher rates of perinatal suicide and substance use. Why? Physical barriers to care, and social determinants of health, right? So systemic barriers to care as well. And generational trauma is one of those. So colonization, mistrust in the medical system, that is there for a very valid reason. And then living between two worlds, being pulled between a traditional and a Western mentality, belief system, etc. But notice I also put that on resilience, because living between two worlds, for people who are comfortable with that, they know how to access resources on both sides. The digital divide is a big barrier for Native families. Internet infrastructure. Mental health services are too far away, and then you can't access them digitally. Needing to go back to work, right? If you need therapy and you need work, which one do you choose? There's no judgment here. But how do you choose? Mental health services might be provided by your neighbor, by your aunt. I got a lot of referrals out on Hopi because people were related to the therapists there. Or mental health services are provided by people who have no idea who you are or where you are. There's a lot of turnover, inconsistency. And then Western models are used that don't take into consideration the way people have lived for thousands of years. And with that means you have to be on time, you can't miss an appointment, and you have to be in the office. And that's hard, uncomfortable, or unfeasible for some people. I want to throw this here. I realize I have to cut this down. I don't usually bump up to time like this. So I'm like, frustrated, but it's okay. It happens. But I want to show this slide at least. History of IHS and health systems. Relationship of Native women with OBGs, right? So for years, up to 10,000 Native women were sterilized without their consent. Yet we expect them, their daughters, their nieces, etc., to trust these systems when they hear these stories, and maybe it happened to their mom. And then CPS or DCS, I still revert back to CPS. This huge fear that systems are going to be involved. And it's not an irrational fear. This happens, right? I do a training on when to call DCS because we are so quick to just pick up that phone when we don't actually understand what's happening with somebody. And then other effects of colonialism, colonization, settlers, right? Traditional ways, increased resiliency. Colonization, assimilation, acculturation did everything it possibly could to decrease traditional ways and thus decrease resiliency. Boarding schools not only took children out of homes, parents didn't know how to parent anymore because they didn't have children to parent. So we lost a lot of parenting traditions. And then generalizing one tribe to another with 574 federally recognized tribes and probably that many unrecognized. It's foolish to act like each is more similar than different. And then acting like our way is the right way. So when white folks come in and provide treatment, we have to really know what we're doing there. And we have to be really careful when we do it, and we have to do it in a respectful way. I am going to ask Melanie and Ernestine if you would like me to stop now, take questions, or what you would prefer.
Well, we can ask the audience if there are any questions. Please, by all means, put it in the chat. And Siran, I'm not sure if you saw, we've got quite a few people that went ahead and
Yeah.
listed their their positions, and lots of moms, lots of daughters, aunts, a lot of women in postpartum and maternal health. I don't see any questions. We do have a few more minutes if you'd like to
Yeah,
continue
great.
until we
I
see a
will.
question. Thank you.
I will. Awesome. And I just went through those titles too. So, okay, thank you. So I put this here because I think it's really illuminating. So these are things that people have been afraid to tell me. I thought I had a great relationship with a client, and I still think I do, or I still think I did, for 3 months before she would tell me that her baby sleeps in a cradle board. In my mind, I can't think of a safer way to sleep. For, for white folks, we're so afraid that a baby's going to roll over or roll off a bed. That's just not going to happen in a cradle board, right? But she was terrified to tell me. She opened up to me about so many things, but she was so afraid that I wouldn't understand why she was doing this and that it seemed wrong and dangerous. Um, and I get that. I understand why she would be afraid to say that. Co-sleeping. Oh, we act like you can never co-sleep. I mean, to the point that I won't even go into how I feel about it, because it's so controversial. Um, I will say, umbrella, I believe in it. We did it forever. We have to do it carefully if we're going to. We have to know, we have to educate. Her father is abusive, right? That some people go right to that phone. That's a DCS call instead of trying to support it. I am still struggling, right? I don't want to admit to you that I'm still struggling after I've been coming to you for help, because you might think there's no hope and pick up that phone and call DCS. I'm scared. What are you scared of? Is it something that I need to be scared of too, and then pick up that phone and call DCS? I have intrusive thoughts. Again, 70 to 100% of us do. It's about asking, what are they and are they dangerous? They usually are not. I don't have stable housing. Again, worried about DCS, or I want to die, right? Yes, it's what we work with as therapists, right? And so support that. Um, okay, so I will quickly say, in terms of skills and resources, I will quickly say community and social supports. When we opened a crisis team on Hopi, we had all of this pushback from the state and the big cities in Arizona that you can't have a crisis team there because there's no services. There's no services, right? As if services are the only thing that can make a community healthy, right? And so what we did was we talked about how, no, we can actually talk about families and friends and community supports and traditional supports, et cetera. And so reframing evidence base in a cultural context and asking ourselves, maybe 1,000 or 8,000 years of this practice is evidence-based. Again, it's really controversial to say that because we're supposed to back it up with academic numbers to trust it. I think we have an ethical obligation to do these things. I think we need to connect mind, body, and spirit. And we need to learn the resources of the communities that we work in, and integrate tribal resources. Handful of tribal efforts. They're in a resource list at the end of this that send out, I imagine. I'd like everybody to have my slides. And then, oh, Elizabeth, don't hurt me. Postpartum Support International is an amazing resource. I've been working with them for, I don't know, 8 years. It's through them that I have my own training and certification and a couple other trainings. Fortunately, they have an amazing website and it's all in here. And I will just quickly show you. This is Arizona's report card, so you know where we are as a state. We're at a C, which, I mean, if you look at this, the country, it's kind of scary because the C doesn't look so bad if you look at some other states. However, we're working to improve these things. And I think a huge part of that is that we are starting to have tribal involvement. I'm not starting to have tribal involvement, but starting to prioritize the tribes and tribal collaboration and involvement. And since I'm at time, I want to show this and make sure that people go back to it because this is for providers. This perinatal psychiatric consult line is awesome. If you are somebody who isn't quite sure what to do with a patient, ask, right? Ask the question. Go to somebody who does know. Being able to admit, I'm not sure, let me check on that, is life-saving. And also keeps people out of systems. I'll point you, this is a tool that I've started using with more than just perinatal clients. But I want to make sure folks look at it when they have my slides. We can use this with anybody. It's non-clinical and it provides a roadmap that people can look at. It's easier in bite-sized pieces for people, but this is a way of saying, oh yeah, okay, these are the things I need to do to be okay. I will make my final point about screening. And it's a point I've already made. These screeners can be very, very helpful. They are essential, use them, but know that they are missing pieces and that the best thing we can do is learn our clients and ask anybody, have you had a baby recently? Are you pregnant? Of course, we're asking these questions. If the answer is yes to any of those, ask them further questions, not just depression, anxiety screeners. The same woman that had the blood transfusion who was told not to go to the hospital, she also was never screened for PTSD, even after going to her postpartum checkup where they knew she had had a hemorrhage. So we need to do better. We need to screen. Brief resource list is here. And thank you. And I'm sorry I went over. I covered almost everything.
Siren, that was wonderful. And actually, if you wouldn't mind going ahead and sending me a set of your slides, we will be able to create them into handouts on our website with the recording of today's presentation. Again, thank you everybody for joining us. And thank you, Siren, for your presentation. And you'll see she's got her contact information there if you have any questions or that you'd like to reach out to her with. And Ernestine, again, it's great working with you. And we have another American Indian, the Health AHEC webinar next Tuesday, and it's going to be with Dr. Molina. And let me pull up my slides. I've got a lot of other things coming up here so I can remember the correct name. Let's see here. It's going to be on December 3rd with Dr. Molina, and he's going to be talking about veterans he's a veteran himself, and it is specifically titled Indigenous Maternal Health for Veterans. So we're continuing on the same theme. And again, Siren, thank you for presenting, and I will be sending out a thank you email to everybody with the information and where to find the recording, and you'll be able to get a copy of her handouts. Again, thank you everybody for joining us, and we look forward to seeing you again at a future webinar. Thank you, everybody.
Thank you.